Next slide, please. I'm Chris Stilla. I'm a professor of pediatrics and section head of general academic pediatrics at the University of Colorado and Children's Hospital, Colorado. I'm also principal investigator of the Children and Youth with Special Healthcare Needs National Health Systems Research Network. I will be moderating today's discussion. We're recording this webinar and it will be available on the Lucille Packard website in the coming weeks. Next slide. Joining me today are three of the authors of this paper and experts in this field. Meggie Okamura, who is professor of pediatrics, internal medicine, and health policy at the University of California, San Francisco. Ife Osunkwo, who's professor of medicine and pediatrics at Atrium Health, and she's also the director of the Sickle Cell Disease Enterprise at the Levine Cancer Institute. And Mallory Sear, who is a program manager for children and youth with special healthcare needs at the Association of Maternal and Child Health Programs. Next slide, please. Please ask questions. We want this webinar to be as interactive as possible. We'll have plenty of time after the presentations for questions and answers. We encourage you all to submit questions in the Q&A box, and we'll try to get as many as we can today, although we acknowledge that given the large number of participants, some will need to be deferred till later. We plan to collate the questions that can't be answered and answer them offline after the webinar. Next slide, please. So before we begin, I'd like to thank the Lucille Packard Foundation for Children's Health and HRSA MCHB for their support of this webinar and the larger effort of developing our National Health Systems Research Network for children and youth with special healthcare needs through a cooperative agreement. This research agenda that we're going to talk about today and also in subsequent webinars was developed as a major part of our initial 5-year cooperative agreement with MCHB and HRSA. The reason for the network is that the number as well as the proportion of children and youth with special healthcare needs is increasing, and the amount of research on improving systems of care is also increasing. However, health outcomes are not really improving for this population, and research is not always well coordinated. The needs of families are not always included in the research priorities. However, MCHB has developed core outcomes for the health of children and youth with special healthcare needs, and efforts between AMCHIP and NASHP have developed system standards, and those are very well articulated. So health systems research needs to be aligned with these outcomes, and the efforts need to be coordinated. Next slide, please. The development of this National Health Systems Research Agenda, again, was a major part of the first 5-year funding of our research network. It began about 3 years ago with a multi-stakeholder process, a Delphi-like process called the RAND Appropriateness Method. And this process and its outcomes were published in 2020 by Ryan Collar and others in Pediatrics. After this effort, we realized that we needed additional stakeholder input to include more families, more diverse families, and more diverse provider groups. So we undertook some qualitative work to get that information. We combined that with the results of the RAM process to identify 6 major areas for research, with questions prioritized within each of these areas: transitions of care, caregiving at home and caregiving processes at home, principles of care, child health care processes, family health, and financing. 7 papers within these 6 areas have been accepted as a supplement to Academic Pediatrics, and this will be published in early 2022. The first of these, Transitions of Care, is available online. Next slide, please. And today's webinar will focus on transitions. Dr. Okamura is the first author of the paper, and we'll start our presentations today. So Meggie, take it away.
All right, thanks everybody for coming today, and excited to, on behalf of our authors, to just kind of share the highlights of the paper, and hopefully you were able to access it relatively easily. Next slide, please. So I am going to guess I'm preaching to the choir for many of you on this webinar, either with lived experience or working with patients. And this is, again, just a basic background that we know that transition transfer from pediatric adult healthcare is a vulnerable time for many adolescents and young adults with special healthcare needs. The well-documented adolescents experience lower continuity of care and higher morbidity. And we've had many decades of really good research describing numerous barriers experienced by patients, providers, systems, and policies in various domains. Next slide. And luckily, many of the academic societies and our subspecialty colleagues and groups have advocated for improving this transition process. In addition, health systems have been working on trying to improve this transition process and the quality of care delivery. Unfortunately, there's not really clear evidence on how to ensure optimal healthcare transition outcomes for everybody. We still continue to struggle with that. Next slide. So as part of this writing group, we were charged with fixing or answering the stakeholder questions which are posed to us, which was, what are the best models to accomplish youth-adult transition planning? How might this translate to other transitions such as new providers, new settings, new schools? And how do gaps in insurance and community supports during early adulthood affect children who use special healthcare needs, health outcomes? And how can we reduce that? So that was a little bit daunting to us. Next slide. Because fixing healthcare transitions is complicated. Barriers to healthcare transitions are complex, as you know, through the multiple stakeholders and domains in which healthcare transition crosses. And we really require a multimodal approach with input from patients and families. And again, many researchers here on this call know there's no single magic bullet that addresses all the barriers identified in terms of the healthcare transition process. And as noted, there's continuing to be a significant research gap in healthcare transitions in order to address many of the aspects and domains that were asked of us and what we tried to address in the paper. Next slide. So our tip of the iceberg recommendations were that, we need to better understand better optimization and implementation of healthcare transition service models. How do we do it? How do we get it done? We need to define the process and outcome measures that capture adequacy of transition-related activities. And also, research that focuses on evaluating fiscal policies that incentivize that process of transition and readiness development, the transfer to adult healthcare services in continuity of care within an adult healthcare setting, so that we can continue and improve that quality of care that we would all ideally have for everybody. Next slide. But in order to address that, we also found that we needed some overriding research principles to effectively advance the field. And in particular for our writing group, and again, many of the stakeholders, first and foremost was to include patients and families. And our colleagues, our next two speakers will be addressing this directly, because most studies don't engage families or youth in the research process, especially at the beginning. And that disconnect between family and youth goals and provider goals in healthcare transitions serves as a source of continuing failure to improve healthcare transitions. By aligning the goals of families, youth, and providers, it provides us opportunities to advance the field by defining appropriate process and outcome measures and generating creative solutions. Next slide. We also need to look beyond healthcare. Many interventions focus on clinic-based interventions, but young adults and their families don't live in clinics. Strategies that work with community engagement, schools, outside programs that fulfill needs of youth, for example, for vocational attainment, will likely allow youth to grow and develop in their healthcare management skills. Again, that sort of, if you improve life on the outside, we improve our healthcare. And again, working with community programs also facilitate in overcoming additional barriers to healthcare and bring cultural and social competencies to the process. Next slide. And bringing in rigor in the real world. And what I mean by that is that we need greater use of randomized controlled trials, quasi-experimental methods that will help evaluate measurement and outcomes, and which are really greatly needed. Currently, much of the research has been driven by single academic center pilots, and that's not necessarily a bad thing. And if we can include those theoretically driven models and evaluations, that'll allow us to greater generalize those research findings into improvements across multiple healthcare systems. So using implementation science strategies to see what works is really critical to change health systems nationally. Next slide. And finally, we need to address policy. And funding strategies are key to implementing the sustainable transition programs, as well as funding grant processes that allow us for more longitudinal studies. Again, many of our research has been hampered by the fact that current data sets are short-term, they end at age 21. So longer-term studies, clinical trials that really look at that transition process is critical. Projects describing cost effectiveness and strategic funding strategies really haven't been widely performed. I know Tom Davis at Geisinger had done some work in terms of cost effectiveness, and there are some under, but there's still quite a paucity of how to effectively fund and measure. And again, state and federal demonstration projects would help advance how best to fund incentives and programs to ensure high quality healthcare transitions. Next slide. So just kind of final thoughts. What's really nice compared to doing this work 20 years ago was that funding agencies are now increasingly prioritizing healthcare transition research. National Institute for Mental Health, NICHD, PCORI, various funders have all started to increasingly fund and prioritize healthcare transition. So it's a great time to really focus on many of these research gaps. Again, that push toward robust development of those transition managers and key outcomes are really needed in terms of advancing this field. And again, theory-driven interventions that are disease agnostic and rigorously tested are critical to changing the way we go about the healthcare transition process. And so moving on to our next speaker, Ife Asunko, who will go into some of the facets we covered in the paper.
Great.
Thank you so
Maggie, I'll
much.
just interrupt real quick. So sorry. I wanted to point out that live captioning is now available for this webinar. So you can access the captions by either selecting the closed captioning button at the bottom of your Zoom screen, or there's a link in the chat that you can click for a web-based view. Please enter any technical issues into the Q&A and we'll take care of them. So sorry to interrupt.
No, thank you very much. And thank you, Dr. Kimura, for handing it off. And it's amazing how the work that was done with this paper dovetails very nicely with the work that we are doing in parallel at my site under a PCORI funded project. And Dr. Akamura had mentioned that transition is very complex. And we took the approach that the triad is a critical component of how to achieve the good outcomes that she mentioned that are really needed in this population of children with special healthcare needs. So we looked at the triad as being comprised of three different components. The patient with sickle cell disease or any patient with a chronic medical illness, the community, either advocacy groups, community-based organizations, and the medical community, including pediatrics and adults. But also the approach and what you need to address is complex, and you need to use a triad approach to do that as well. So social issues, psychological issues, and medical issues. And the size of the wheels are intentional. The patient is the most important member of the triad, and the psychosocial issues trump the medical issues any day. Next slide. So we did a community stakeholder assessment to find out what exactly did our patients, community members, and healthcare providers need around our agenda for transition. And 5 things came out as emerging themes. They wanted care to be standardized and consistent. And patients specifically said, we want an action plan for when we go to the emergency room. And providers said, we wanted a guideline that if we see a patient with sickle cell disease, we knew what to do every time, every patient. Patient education was a really important thing. They needed additional resources, provider education, and partnerships across the different provider aisles. Peds and adult care, acute care and ambulatory care, inpatient and ER was a pretty important component that kind of emerged. Community engagement and improving the patient-provider relationship was also highlighted as important things to address in whatever we decided to do from a research perspective with transition. Next slide. So we were funded by PCORI to do a prospective study looking at transition, and we chose as our research component looking at peer mentoring to improve transition. But at that time in 2016, there was really no standard for transition for sickle cell disease. And we figured, why would you do a study and not have the standard? So we decided to compare peer mentoring with no peer mentoring, but offer every site, all 14 sites, a standardized process improvement model for doing transition using quality improvement. And we wanted to have change across medical settings and the community. The guy presented in the picture is one of our co-investigators who actually has sickle cell disease and died while we were writing the grant. And we named the project after him, Trevor Thompson, because he was an advocate for transition and also for peer mentoring in the educational system. Next slide. But it really highlights why it's important to do this work and do it now, because we are losing patients every day. And so our standardized intervention involves quality improvement, community engagement, and education around transition and what happens when you change care settings from pediatrics to adult care. And we use the gut transition model as our guide, and we use the model of improvement as a QI package, and we put together a practice change package for all sites, all 14 sites. We had urban and rural, academic and non-academic, so different settings, different types of providers, and different levels of experience as community advocacy groups in terms of who are partnering with us. Next slide. And we looked at each partner as an equal member of the research triangle. So the doctor was not more important than the patient and not more important than the community agency. So our SMART aims were as follows. Sickle cell disease we know is a complicated disease. And as Dr. Kumura said, these patients die early. They have a lot of morbidity and mortality. It's actually a 3 times higher mortality in young adulthood for sickle cell disease than younger ages and older ages. So it was imperative that we do something about that. And our aim was to improve the health of these patients by implementing an evidence-based model for transition across pediatrics and adult care. We had a timeline, it was 24 months, and we had our model and our guidelines for the gut transition 6 core elements. Next slide. She had mentioned, Dr. Kumar had mentioned the need for process measures and outcome measures, and we chose 2 different measures, one for process called the process measurement tool, and one as an outcome that was a desired outcome by both the patient and providers. And they wanted a plan for emergencies. And our goal was to reach 75% compliance with every patient having an individualized treatment plan for when they got sick in the ER on the hospital. And the process measure was customized to our sickle cell clinic, leveraging work done by gut transition to standardize the process of what we do for patients, every time across pediatrics into adult care. Next slide. This is what our tool looked like. And you can find this tool on the gut transition website. They're going to have a link put in the chat box as well, if you would like to see it. This was tweaked for sickle cell disease, but the components are the same. You wanted to have a way to measure what you're doing in clinic in a very structured and organized way so that you can compare apples to apples and not apples to oranges. Next slide. And this is our emergency care plan tool. You may see it's very familiar with the asthma action tool. We spent about 2 years before we got funded working with our patients, community members, and our providers to figure out what exactly should this look like. And it was fun because they wanted, tell me what I should do at home when I'm stable. What should I do at home when I'm well? And then when I get sick, so the green, yellow, and red zone at home. And then when I go into the hospital, show the providers what to do for me when I'm really sick, when I'm getting better, and what is my discharge plan. So you have 2 different sides to this acute care and home management plan. Next slide. So what happens when you measure yourself against yourself? You always think you're better than you really are. And we tried to teach our sites to really measure themselves based on a structured tool, that process measurement tool. So the panels above show that everybody measured themselves better than they really were. Some people scored a 0 and thought they scored a 30 or 40%. After 2 years of monthly coaching and reiteration of this process, we were able to get our sites to where they measured themselves equally according to what the standardized tool looked like. Next slide. So over 2 years, what happened? We actually did it. We were able to implement a structured process for how you take care of a pediatric patient from ages 16 to 25, all the way through to when they go into adult care and remain in adult care, from the provider perspective, leveraging, partnering with the community members and with the patient advisor on every team doing this work in the clinic. And so we noticed that about 92% of our pediatric clinics and 71% of our adult clinics were able to score 90% or higher on their process improvement tool over the 24 months. This is impressive because some of our sites scored a 0 at the beginning of this process. Next slide. And using quality improvement, we kind of walk with them every month in our coaching calls, how to do this work step by step with a lot of coaching and a lot of offline calls to kind of help them figure out what works for their independent site. Every clinic was different. Their staffing model was different. Their administrative support levels were different. Their level of technical expertise and exposure to QI methodology was different. But if you look at the panel on the right, pediatric patients and adult patients were able to significantly improve their outcome in terms of getting their emergency care plan to the level that we desired over time. And even during COVID, we didn't find that significant dip in process because this now became embedded in how they did work every day in their clinic with their current staffing model. Next slide. So what did we learn? We learned that transition is really important and a major concern for sickle cell disease and for all children with special healthcare needs. You can actually standardize a program for transition. It can be done and it should be done. And using quality improvement makes it feasible. You do have to have a validated tool to measure programs compared to each other so that you don't have this perception of I'm doing better than I really am. And we looked at 14 different sites across the Southeast and the Northeast, and we saw significant progress over 2 years in implementing this structured process. We believe that community partnerships was critical. Having the community-based organization held us accountable, having the patients on the team held us accountable, and it has to be a part of your process from the inception all the way through to the implementation. And we also found that there was one member of the team that was absolutely needed. A coordinator, navigator, care manager, whatever you want to call this person, but somebody had to be the glue that was a liaison between the patient and the medical team and the community. Thank you very much. I'm going to pass it over to our final speaker, Mallory. Take it away.
Great. Thank you so much, Iffy. Maggie and Iffy really queued up some of the things that I'm going to talk about. And I kind of want to bring us home with where do we need to go from here in terms of research, in terms of the transition conversation, and share a little bit of my personal experience navigating healthcare on the adult side, because although I'm the quote unquote youth perspective, I've been navigating adult healthcare for about 15 years, which is as long as we've been having this transition conversation. So I'm happy to be a part of this and very excited for everybody that is joining us today. So thank you. So the first thing I want to talk about is how are we measuring transition? We have the National Survey of Children's Health that we measure up to age 17. And when does transition really happen? 18, 26 after the ACA, if we're looking at insurance. It all varies a great deal. And if we also look at, you know, who is reporting this information, and one thing that I learned during my time with Got Transition was if you talk about transition with a parent or a caregiver, and then you have that same conversation with the young person who is transitioning, you're probably going to get very different information. So, you know, as Maggie said, patients don't live in a clinic. How are we capturing the bigger picture? You know, after that transition discussion is had with an adult provider, do they go back? Did the young person feel respected? Did they feel valued? Did they feel listened to? And if that transition falls off the map, if it doesn't continue, are we capturing why? You know, we got to remember to look at the social determinants. Transportation is a huge issue. You know, changes in insurance, all kinds of things. I mean, especially with COVID, which I'm going to talk a little bit about, you know, the transition landscape has changed. Medically complex individuals don't even feel safe accessing healthcare in a lot of ways. So we need to really broaden the discussion of how we're capturing that and really focus on the idea of patient satisfaction, not just that the appointment or the discussion occurred. There's also thinking about, you know, cultural components of what does transition look like, and how are we and why are we as, you know, professionals or medical professionals, you know, setting these standards, and how much are we projecting what we believe a successful transition looks like? You know, again, during COVID, you know, I've seen a lot of young people, young adults with disabilities and medical complexities who are moving home, who are changing their living situation or their healthcare situation because they want to be where their natural supports are. And this is a very scary time for anybody to be accessing healthcare. And so if you're looking at something, big like a healthcare transition, but you have providers that understand your needs during this time, and you know that you're going to get the quality of care that you need, we need to reconsider, what this looks like and how we're measuring success. Thinking about the idea of family within research, we typically within MCH define family leader or family as a parent of a kid with special healthcare needs. However, the idea and the model of family is evolving. And part of that is because our children and youth with special healthcare needs are growing into adults who have families. And the families may not be, a nuclear family with, having children or, what we sort of idealize in our own minds, but they are still a family, and they still need to be involved in these very important discussions and research opportunity. We need to start engaging, different voices, having these different voices at the table to share their experience. And one thing that I think we need to really shift away from is within transition, there is a lot of youth don't care, families aren't engaged, youth don't manage their health, poor self-management. And what a way to disengage people from being involved in the conversation. And I have seen within the healthcare system, so much blame. And even within public health, we need to start shifting the conversation to those systematic barriers. And we talk about this a little bit in the article, but it's more than care coordination. Care coordination is great. I've never had it. I know it can be great, but we are out there managing. I've always, as an adult, managed my own care. I'm eligible for additional supports. My husband and I have made the conscious decision that we are each other's natural supports. And families and young people can plan and prepare and do everything within their control. But if there is nothing welcoming them on the other side, it's all in vain. And so I'm going to talk a little bit about my experience and how we can make that shift. Next slide. So this is just the teeny tiny micro snippet of my transition experience. I have been, as I said, navigating this for a decade and a half. I moved to Boston to go to graduate school, where I navigated a healthcare transition. And then my now husband and I made the decision to move to Colorado after I finished graduate school. And what I think is really important is that transition is not stagnant. Transition doesn't end when you find your first adult provider. I should have the freedom to move to another state where apparently the healthcare is really great, because that's where my life is taking me. And we had an incredible PCP in Boston who I will say worked for a safety net hospital, which is not typically where medically complex individuals are referred. But that's a whole other research topic. But we got the best quality of care I have ever experienced. And so it was really difficult leaving her, but due to a lot of variables, we chose not to stay in Boston, and we were moving to Colorado. And I was like, oh, great. Colorado is like the transition, like capital, like this, we got the hookup. It's going to be great. So here I am, a national healthcare transition expert, advocate. I've got all my ducks in a row. I've got my Boston provider talking to transition champions in Colorado. I've got my portable medical summer. I am got transition. Like, let's make it happen. So we're doing this, and we're trying to coordinate everything. And I got a text message from my Colorado contact that said, nobody is interested. So what do you do with that? Because I'm planning, I'm preparing, I've got my spreadsheets. You ask my husband, I am a planner of all things. But I was physically told no provider in Colorado wanted me. What do you do with that? So unfortunately, I got to Colorado because I had a job waiting, and this was our plan. And it took me ending up in the emergency room to get connected with primary care. And that, we are told and judged and, don't go to the emergency room, primary care. What if you can't get that? So I was connected to a provider, whatever, through the emergency room. That provider she had 1 star on Yelp, and I'm not one to go to Yelp for providers, but I was like, maybe I should just check it out after a few encounters. She wasn't signing prescriptions for my life-sustaining medical treatment. Like, she was just off the grid. So that did not pan out. And then I switched. I don't know all the transitions, but basically I've had 5 PCPs in 6 years, and some of those were great. And then my insurance changed. Some of them were great, but they were residents, so they cycled out. And nobody thought that as a medically complex individual, maybe I shouldn't have a doctor that's going to leave in 2 years. And then I had doctors that sort of bullied me into having them as a PCP because I was nifty. And I'm sure they wanted, me on their docket, and they made judgments. I walked into the room and they said, "Oh, do you have this medical condition? Because you remind me of my other patients that have that." So it was very clear that she had not looked at my chart. She just saw, like, ooh, she's nifty. But she was very combative anytime I tried to advocate. It was a very traumatic experience. And when I was in the hospital for a very severe GI bacteria that I got, don't eat seafood in Colorado, guys, don't recommend. I had no support. I was not listened to. I almost died. And it's very traumatic to even relive. But it showed me how broken our adult healthcare system is. And I'm not saying that there are not good adult providers out there, because I know that they are. I'm very fortunate to now have one who listens to me, who feels, who respects me. We have a dialogue, a partnership. But I am terrified that if I had a crisis, I am not safely cared for in the adult system. And there is a whole universe of medically complex adults who have had similar experience. I know one young woman who is actually starting an initiative to address medical PTSD, because that is very real. And so as we talk about transition, part of that is understanding why a family may not want to do X, Y, or Z, or entertaining, have the conversation. If somebody is saying, I know that if you do X treatment, this outcome is going to happen, listen to them. We talked about on our practice call about how conversations had in the emergency room do not even translate once the patient gets admitted. And that has been my experience, where I was able to get what I needed in the ER. And then once I was admitted, I was told I could not manage my own care. I was flushing my central line in the bathroom because I was told I could not use what I needed to keep my medical device, and they just couldn't get it. It was awful. I don't typically talk about this experience because the transition conversation often stays in the pediatric landscape, but we need to start broadening the conversation, involving adult providers and understanding why nobody wants us. I know we're not profitable. we are working right now in a system that is incredibly overburdened. People with disabilities are being evaluated. Like, COVID has really, really made these inequities for medically complex individuals come to light. People with disabilities are writing their wishes on their arms because they're unable to have an advocate with them. And we have total strangers deciding whether our quality of life is worth it. And those are the conversations that we need to have. And it's scary, but we need those adults who are experiencing this side of the system involved in the transition conversation, because we're here, we're ready, we're doing the work. But if nobody wants us, what are we supposed to do? And we need to infuse education around how to care for and work with. Don't do things for, do things with us. We are coming to you, sharing our lived experience, our expertise. I've had my disease for 36 years, and I'm being told by a med student that I can't have antibiotics because it might not work. How about we try it? You just started yesterday. So, it's really, really difficult because we advocate and advocate and advocate until we break. And that's the truth. Yeah. So with that, I will turn it back to Chris. Thanks.
Valerie, thank you so much for this great story, how it applies to the real world. I mean, we've got just so many great questions that can help people like you if they're well answered. So thanks for your honesty, and more is good. And I'm not being very articulate, but thanks. We have so many good and deep questions really that have been posed. One that already was discussed a little bit in the chat that I'll start with, which is, who is the most important member of the transition team? And I think we know the answer to this. The pediatric doctor, the adult doctor, the patient, the transition coordinator, or the parent or caregiver. In the chat, there was some consensus that it was C and E, the patient and the parent and caregiver. But I wanted to open it up a little bit to the three of you to discuss just for a minute or so how that works or doesn't work, and why that works.
And I'll go ahead and start, because I think that sometimes in healthcare, we forget why we're in healthcare. We became doctors to take care of patients. So why would I be the most important person in that equation? I think it's an ultimate form of an ego trip to think that the doctor or the healthcare system is the primary place or primary important person. So I vote for it's the patient. Now, I kind of lump patient and caregiver together because you really can't separate a patient from their caregiver. There should be some separation as they achieve independence. But that's a process, and not every patient can achieve independence. So I talk about interdependence. And so as a provider, both peds and adult care, I want my young adults to become interdependent with their family members or caregivers and their healthcare team. So I don't think I'll separate. From internally to the health system, the coordinator is the most important person to kind of help coordinate things between healthcare and the recipient of healthcare, the patient. So that's my thoughts.
Great. Maggie, any thoughts?
Oh, yeah. So I would agree that, internal medicine is sort of interesting. I'm an internist, and I have a primary care practice that focuses on adult with special healthcare needs. And I would say that generally my colleagues, when we think about patients and their families and caregivers, many of my older 90-year-olds are being cared for by their children, their spouses. That family-centered care is critical. Regardless, it's not foreign to adult medicine, but it does get quickly superseded by the pressure. So I saw lots of comments about not finding providers. My own institution is now close to all new patients. And it probably will be for the next several months because we have just a loss, an exodus of primary care providers. It's hard. There's a shortage out there. And so we're talking about a global system. I mean, there's so many things that we could talk about and spend hours about. And what we're seeing is more of defectiveness in the healthcare systems overall, right? It's affecting healthcare transitions because our system isn't perfect. And so trying to strive for that, given the fact that we have developmental needs and transitioning issues that are specific to the transitioning world, living in a microcosm of this larger, spectrum that is US healthcare.
So I had another question teed up, but I wanted to follow up, Maggie, on your point that you just made and pose this back to the group. There are not many providers who will see young adults with special healthcare needs. Is this a payment issue? Has something changed in the payment world? Is this another, ability to assemble a team issue? What are some of the root causes that we could start to work on?
I think out of all of them that you had mentioned, so I have a risk-adjusted panel. So for the number of patients that I have on my panel, it's formulaic. And so it actually lowers the number of patients I have. So technically I should have 200 patients. So I have a small primary care practice per half day. So that's 200 per half day. And it went down to about 140. 150 because of risk adjustment. So that allows us to spend more time for the case management. But it's, with the pandemic, alluding to what Mallory's going through, it's kind of brutal on both sides. With the pandemic, there's a lot more that I have to deal with on a day-to-day basis. I probably spend as much more time outside the clinic with my patients than in the clinic, for management. And that puts a lot of pressures on primary care physicians, right? Because if you don't have the infrastructure, so I'm in a large quaternary care medical center that has medical complexity built in. I have a DME manager. I have a pharmacy, a pharm tech. I have somebody who can take care of the G-tubes and trachs in my adult primary care practice. Whereas if you're a solo practice, especially when you're in rural areas or in California, this is a big problem because unless you're in an academic center in an urban area, if you are in, again, the small, the smaller practices, it may be much harder to do a lot of that care coordinating case management. My first patient visits, are often, just to get to know, it's 40 minutes. And yet, for incentives for RVU productivity, it's really hard because you have to meet your RVU targets, right? And so there's multiple layers in terms of primary care delivery and even specialty care delivery.
Yeah, and I want to piggyback on what Maggie said. The other thing is expertise and comfort. So I'm a pediatric hematologist, and my practice right now is 18 years and older for sickle cell disease. I have zero experience looking at heart attacks and STEMIs, but I can do sickle cell disease. And we just haven't trained our providers from medical school to understand the diseases that start in childhood and what happens as they get older. So if a provider doesn't feel comfortable, they're going to back away. They don't want to make a mistake. So I think it's a combination of several different things. I'm learning how to read an EKG for an adult. I'm learning about prostate cancer and diverticulitis, right? But I'm a pediatrician at heart. And so the communication style and the care coordination that I use for my adult sickle cell patients is really a pediatric term of philosophy, not the way the adult hematologists typically function with their patients. Maggie, Mallory, what are your thoughts about the barriers? Because you've seen a lot of this firsthand. I'd love to hear what you think.
Yeah, thank you. Well, and what you said about providers not understanding these diseases, I think is a huge issue, especially within the rare disease community. I mean, I'm the oldest living person with my condition. I don't expect providers to understand it. And frankly, I don't want them to have preconceived notions. I always say, my favorite words when I'm meeting a new provider is, "Oh, I've never heard of that, but I'm willing to learn with you and from you." And we have a conversation. And I think one of the biggest things is that, and this is a generalization, doctors don't like to not know things. They don't. And
So
you know, I
true.
think it is. And you know, I think part of that is risk and liability. That always comes into play. But you know, we need to shift that paradigm and that discussion of you know, we all bring things to the table, right? Like as an adult, I've had this sort of like weird shift about how I think about healthcare of I am going to a total stranger to trust them with my life who have about, you know, the same sort of technical experience as me, but in a different way. And somehow I'm just supposed to go, okay, whatever, like whatever you think, you know. And so there's that power dynamic that is historical and patriarchal that we don't really talk about enough. But I think for me, you know, just having providers who are willing to learn and willing to work with you, for me has been the biggest thing. And when people come in with preconceived notions or, oh no, we're doing things this way because I'm the doctor and I've been told that, that is a great way to shut down that partnership.
And note that that's actually across the board, right? I mean, regardless of the condition that a person comes in, every human being wants to be treated with respect, knowledge, that humble inquiry. Because I mean, you know, there are many diseases that people acquire that are rare, and those, you know, that we don't know about, and that can happen every year of somebody's life. And so we're talking again about that greater scheme of how do we just improve care to everybody in a way. I feel like if we could make transition perfect, we just have the perfect healthcare system too. I think all physicians are striving. Well, you know, we still have issues, and that's a workforce issue that other colleagues can work on too.
Right.
Oh, and
So there's so
I
many factors at play here. There's training needs, there's comfort needs, there's culture change needs, you know, doctor as a smaller part of the package. There are some good things. Maggie, you've mentioned that you can spend a little bit more time with a somewhat smaller number of patients now. On the other hand, the number of patients in the world or in your area is growing, so that makes it hard in some ways and easy in others. Putting this together with the question from the chat, it's so frustrating for parents and patients when there are good tools and information and resources out there, but no provider or provider team to coordinate and run all that. So what should we focus on first? This is a puzzle with so many pieces. What corner do we start in?
I think the most efficient way is to start with what we have. If we have tools, use the tools. Let's teach you how to use the tools. And that's how we did it in Charlotte. We have got transition tools. They've been around for a while, but nobody used them. Everybody said they were using them, but they really weren't using them. So we began with the lowest hanging fruit. Okay, let's figure out how to use what's already available and then use that process to figure out what else needs to be done. But the other thing is engage your patients. You can't get anything done if you don't listen to the voice of the recipient. I may want to change ER admissions. The patients want an ED care plan. So what do? An ED care plan. Because that's what's going to work. If we do admissions, you can't fix admissions without fixing the ED care plan issue. You know, so use what works and engage the patients.
Wow, Iffy, that was great. I think we can say that about 12 times in a row and not repeat ourselves. Thank you. Maggie or Mallory, reflections on that?
Yeah, I mean, I agree. I mean, first capitalizing on the, you know, and maximizing what we can do. But I think some of the issues with capacity is a problem. And this is where we talk about funding and policies, right? If you do the best, so if Iffy has this whole setup with the ED, she's got her care plan, but she tries to call my clinic, it's closed. So you can't do anything. And what do? And then you're stuck with the ED where Mallory had to go to, right? And that's not a great place for getting your maintenance care dealt with. They're going to check. It's like, are you dying? Oh, no, you're not. Okay, bye. Right. Call me when you're dying, and that's really a terrible place, to be. And especially to be, I call it medically homeless or effectively medically homeless. And that is traumatic. And so again, that going back to the multimodal, when we think about transition, it's not just high, readiness. Okay, we've maximized what we can do. We need additional help to bolster some of the system level problems that we've had. That could be training, capacity. And right now, capacity is a big problem, at least in I know it looks like in Vermont and even in the San Francisco Bay Area. People who are otherwise healthy can't find, healthcare.
We need a system that's good enough to attract people as well. Yeah, great. Here's another question from the chat. Can you all talk, and Mallory, I'd love to hear your perspective, your experience about balancing standardization of care and having a plan in place for people with special healthcare needs to provide individual patient-centered care. And what have your experiences been like with that?
That's a great question. And I was actually just thinking how to frame that, because for me, I come back to my experience in the hospital that was very negative, and I know that there's again a disconnect between primary and specialty care and being in the hospital, but there also sort of shouldn't be, but there is. And I was physically asking, how can I change your policy? This policy that you have doesn't work for me. It is detrimental to my health. And I was saying this as somebody who worked for our state Medicaid program. I literally wrote policy. So I was trying to I understand that you are working within certain constraints. However, what you are telling me is something that is very bad for my unique situation. And there wasn't a process to accommodate that, it felt like. And so for me, just being able to, have some sort of workaround or exception, or, instead of having it in my chart that Mallory needs to flush her line with heparin so she doesn't lose it, they put Mallory will not access her own medical device and has agreed to this, which was a blatant lie. So, again, we're doing the blame thing, and there's not collaboration. And so, for me, every time I tried to advocate, it was well, talk to a patient representative. Nobody ever brought that person to me. I somehow, in my very ill state, was supposed to obtain an advocate in this moment. And so I think there just needs to be that infrastructure for when these patients come in who don't fit in the checkbox, and not putting that on the patient, because what happens in the adult side is that it's all you need to do all the follow-up. If you need your annual appointment, you need to do all the work, or they're hoping that you'll sort of just phase out and then they can take on more people. So, for me, it was just really wanting to know the process for these policy changes, or how I could simply get in a medical accommodation, I think.
Great, thank you. There's a couple really good questions. I think I'll pivot, because we have time for about 3 more. I'll pivot a little bit to workforce and education. We've got these system changes. We know that reimbursement needs to be different. We know that we need more people who care to take care of adolescents and young adults. How do, from those of you who maybe participate in education, how do we get adult providers on board with embracing the concept of caring for medically complex young adults or young adults with medical complexity. How do we do that? Any insights, Iffy, Maggie, or Mallory, from your point as an educator from the other end?
So we struggled with this. We've been struggling with this for years. Sickle cell disease is a pediatric condition. They usually die before age 21, and now they're living to be 70 and 80, right? And the adult providers were not trained on sickle cell disease up until much recently. And even then, recent fellowship graduates have very little sickle cell disease knowledge. Hospital medicine, ER, the same issue. So the question is, how do you position your argument or your request to support their goal, their bottom line? What's in it for them? So I took the approach that, okay, asking for you to be passionate and loving and care about these people is not going to be the issue, that we've done that. So what does it mean? The ER wants you in and out of the ER in 4 hours. So I'm going to try to get them in and out of your ER in 4 hours, use this care plan. The adult hematologist wants to have a guide in terms of the easy to follow guideline for hydroxyurea, whatever the treatment is, I give you that. Inpatient, how do I treat them so they don't stay 10 days in the hospital? Follow the care plans. We have to figure out what was the shtick for each stakeholder and speak to that. It's a transactional way of doing medicine, but that's how we got to where we are, right? And then as they see the benefits of the intervention that you're putting in place, they begin to like, oh, it's not that bad. It's not that scary. And then I gave them a number. If you don't know what to do, just call a friend 24/7. They call my number for 7 years. You know, it's a horrible way to live because I have burnout, but it was important to get the ball moving. So it's complex, but you got to figure out what's in it for them. How do they save time, make more money, spend less, get you in another ER, meet their quality metrics so that they will be willing to do what you're saying. It's good care, but you got to get them to buy in first, and then they see the value of what you're recommending.
Okay. I want to add, I know we have 1 minute left, but I think within medical school, we need to infuse disability awareness. We need to talk about the rooted ableism within healthcare, and it needs to move from tokenism, not having one person with disabilities come in and talk to one class every few years. It needs to move to full integration, where that is part of the curriculum, and people know it's a thing before they get into the field and have somebody with medical complexities thrown at them. It needs to just be infused in all of the training and curriculum.
And I agree, it's that common support, right, from medical school, residency, and faculty practice. I surveyed all our general internists in our GGIM practice, or general medicine practice. Many of them are very interested in young adults. And I think that when we had a transition pilot, and everyone was really happy to take on a youth, especially when the subspecialist was able to give input. Again, going into, we can't make someone a sickle cell specialist. And I don't think you assume that primary care will become a specialist in sickle cell. You work collaboratively with your colleagues, and you're there working as a team, right? This is a team, it's a village, right? It's the medical village that we support everybody. Not everyone has different expertise, but again, in a kind and respectful, non-ableistic way. But this is, again, going back to the humanism of medicine that we still need to work on. Not everyone in med school, maybe pathology was a good place to be, right? For some people.
Great. Well, thank you so much. I'm very sorry that we're at time. Not only are there a lot more good questions, but there are a lot of good ideas in the chat that we'll collate, take to heart. This has been a really good working hour, honestly. So thanks again. We will answer as many questions offline as we can. Please continue to visit the Lucille Packard website, which is updated very frequently. We would also like to talk about the next webinar in this series, which will be centered on the caregiving at home and the parent caregiving experience paper that will likely take place around February. So thanks again. And thank you to our panelists for just an incredible discussion.